Health radio and television program on the radio at AM 1240 KNRY, AMP's cable television channel 24, and on the web at www.ampmedia.org. Join our rotating host and their informative guests live every Monday afternoon at 4 o'clock. The purpose of the Your Health radio and television program is to help get, make, and keep listeners and viewers like you healthy. And now, ladies and gentlemen, on with the program.
Welcome back to Your Health radio and television program. I'm Dr. David Morwood. I am a board-certified plastic surgeon, and I'm so pleased you could join us today. My very first special guest, Dr. Bogdan Eftimie, oncologist.
Thank you.
Dr. Eftimie, thank you so much for being on the program.
Thank you very much.
Before we get into our main topic during this segment, which is melanoma, something that we read about a lot in the news, I'd like to back up for a moment and talk about being an oncologist. What do we mean by that? What's an oncologist?
An oncologist is a physician that has a little bit more training beyond what one would get in primary care. So for example, I did 3 years of internal medicine, and beyond that, usually one gets 2 to 3 years of advanced training in cancer care. That's what an oncologist is. We actually deal with both diagnosis and management of cancer and cancer-related symptoms and problems.
Okay, so you're a specialist in the diagnosis and treatment of cancer.
That's correct.
That's an oncologist.
That is an oncologist.
And Dr. Eftimie, I noticed from your very impressive resume that you're board certified not only in oncology, but also in internal medicine.
That's right. I did my boards in internal medicine, oncology, and also hematology as well, which is its own subspecialty, and that deals with both malignant hematology, such as leukemias or lymphomas, or just benign hematology.
So I think it's really important for us to teach our audience, whether they're listening or viewing, that many specialists will already be board certified. In other words, you could have, had you elected to, become an internist and practice internal medicine.
That's right.
But instead, you elected to go beyond that and get board certified in oncology and hematology.
That's right. And it's the same way that a cardiologist would get boarded in internal medicine, but then they would go beyond and also get boarded in cardiology. So those are all subspecialties that are similar to oncology.
Now, Dr. Eftimie, is it common for an oncologist to also be certified in hematology, or is that uncommon?
No, it's fairly common. Most programs in the United States prepare you to take care of both hematology and oncology. Most people who graduate from these programs choose to get boarded in oncology, but you can practice as a hematologist as well.
I see. And where did you get your training?
I received my medical school training at Loma Linda University, which is in Southern California, and I did my residency there as well. That's the internal medicine residency. And then I actually did my subspecialty training in hematology and oncology at the University of California, San Diego.
In San Diego and Loma Linda. Well, I appreciate you coming on the program, Dr.
Thank
Eftimie.
you.
And how long have you been in here in Monterey?
I will have been here 2 years in approximately 3 weeks.
Well, you're the so-called new kid on the block, and
That's right.
It's great to have somebody with such excellent training and
Thank
well-versed in all the new therapies.
Thank you.
So, Dr. Eftimie, we promised to discuss today for our audience this subject of melanoma. And you know, just the diagnosis of melanoma will oftentimes startle people. So perhaps can we start by identifying how you make the diagnosis of a malignant melanoma?
Sure. So melanoma is an abnormal growth of a normal cell in our body, which is a melanin producing cell. It's called a melanocyte. And these melanocytes are actually cells that we need to protect us from the damaging UVB and UVA rays that come from the sun. However, there are times when one of these melanocytes loses its control over how much it should grow and becomes what we call malignant. It starts growing uncontrolled, and it keeps growing and growing and growing. And as a consequence, it can actually get out of its normal location and start spreading. When it starts spreading to other areas of the body, we call that a metastatic or malignant melanoma.
I see. Now, Dr. Eftimie, that's very important. You made a couple of very important points. That the melanocyte, which produces melanin, that's in everyone's body. Everyone has melanocytes.
Correct. That's correct.
And that's a normal cell.
That's correct.
And it's helpful to us to produce melanin. But it's when that melanocyte grows out of control, is that what you would say?
That's exactly correct. And there are many mutations that we have identified as the cause of why a normal melanocyte may start growing uncontrollably. And in those cases, then it becomes malignant. For example, there are a lot of people who have moles. We call them nevi. And those moles are actually a concentration of many melanocytes, and they look dark for most people, although there are some moles that are not dark. Those moles occasionally can turn to be malignant. They can become dangerous. But for most people, they don't. They actually are called benign moles, benign nevi.
So why is it, or do we know why certain melanocytes or certain nevi or moles will degenerate into a malignant condition or a malignant tumor rather than just a benign tumor or benign mole that I'd say 99% people have, right?
That's true. We have some ideas in some cases, but I wish I could say that there was a bullet that we can identify. We know that there is an association between sun exposure and melanoma formation. So for example, we know that people who are fair-skinned, meaning that they don't produce a lot of melanocytes, and those that actually burn easily when you go out in the sun and in 20, 30 minutes you're all red, we know that those people have a higher incidence, meaning that they get melanoma more often. We also know that, for example, in Australia, people over there, the rates of melanoma are actually higher, and there is an idea that because of their increased sun exposure, they actually get more melanoma. However, I should just add that in spite of sun protective measures that we have taken, and for example in Australia, they're very, very good about wearing wide brim hats and sunscreen and wearing sun protective clothing. Even in spite of that, the incidence of melanoma has kept increasing for the last 20 years. So we know there is an association. We just don't know that that's truly the only cause that goes to melanoma.
Dr. Eftimie, on occasion, we read about the hole in the ozone layer and how that may be becoming bigger because of the use of some aerosol agents, etc. Does it seem to be a relationship, or is there a relationship between the ozone layer disappearing and increased melanoma, or do we know that?
The ozone actually is very good at absorbing what are called UVC rays. And there are UVA rays, UVB rays, and UVC. The UVC rays can also play some role in the formation of melanoma. We know that UVB are the more important rays in forming the melanoma. So the answer is yes, it could play a role. However, fortunately, we haven't seen those holes get any bigger than they were in the early 1990s. And hopefully we can get them even smaller so we can actually decrease that risk. But I believe that there might be a little bit of risk with that.
Okay, so let's recap. We've said that everyone has melanocytes.
That's correct.
Which produces melanin. That's a normal product that we want in our body. It gives us some protection from the sun. There's a difference between a benign tumor or a benign mole or nevi and a malignant melanoma.
That's right.
That's when you said the cell loses control and starts to grow rapidly or out of control.
That's correct.
Now, you talked about something else, and that's important. In the medical slang, we talk about a MET. That's really short for metastasis. What do you mean by a metastasis?
A metastasis is the ability of a cancer to move beyond its initial location. So for example, if I have a mole on my arm and that mole is biopsied, meaning that a dermatologist or a plastic surgeon takes it out, a pathologist looks under the microscope and says, yes, this is a malignant melanoma, it is a cancer. In that case, we would actually do what it's called a staging procedure, which in some cases involves the use of CT scans. And it is found that now I have a growth, a tumor in my lung, very much away from where the melanoma was. We will consider that as a metastasis. Melanoma tends to go to different areas of the body indiscriminately. It likes to go to the liver, likes to go to the lung, likes to go to the brain. It also likes to go to the lymph nodes close to where the melanoma was initially. And that's what a metastasis is. It's any location outside of the initial presentation.
Okay, Dr. Eftimie, now this is going to be one of these segments where I learn a lot, and I want you to teach our audience about this as well. Now, there's a difference between a malignant tumor sort of locally invading into an adjacent structure, correct? Like maybe
That's very much correct.
Maybe a sarcoma would do that, invade the structures adjacent to it. And I think there's a difference between what we call a satellite lesion and a metastasis. Is that true, or am I?
That is true. And there is such a thing as a staging in melanoma, where we stage melanomas in stages from 0 to 4. And a stage 0 is called a melanoma in situ, meaning that the melanoma has actually not progressed through the bottom layer of the skin. It has not gone down. So that can be taken out, and for all intents and purposes, that's the whole treatment. Stage 1, 2, 3, and 4 are dependent on the size and depth of melanoma, meaning how deep does it go in the skin. That's usually stage 1 and 2. If there are lymph nodes involved, so for example with my melanoma here, if there are lymph nodes involved in my armpit, that would be a stage 3. And a stage 4 is any melanoma that has distant disease. For example, my initial melanoma was here, and now I have liver involvement here.
Okay. Well, Dr. Eftimie, before we go further, and this is fascinating to me, how is it that a person might be suspicious, or how does a person know whether or not when they have a mole, we all have moles or nevi.
That's true.
How is it that they might be suspicious or know that they had a melanoma as opposed to a benign mole?
That's a very good question, and this is something that we have been trying to do for the last 20 years, and at least here in the United States, we have been fairly successful of doing this. And it's an acronym. We call it the A, B, C, D, and E acronym. And what it is, A stands for asymmetry. If you see any mole, that if you cut it in half, if you just, imagine that you cut it in half, if one half is not similar to the other half, if let's say one half is round but the other half is very ragged, that should be a suspicion that there might be something else going on. That's A. B stands for border. If the border, instead of being smooth and round, is very ragged, very jagged, just like the inlets when you look at the map and you look at the map of the United States of the Pacific Northwest with the San Juan Islands, if it looks like that, that can be a problem. C stands for color. Any color change, if it's very dark and now it starts becoming red, or if it's lighter and starts becoming darker, that could be a problem. D stands for diameter, and anything greater than 6 millimeters, which is basically the tip of a pen. That's the other end of the pen, that is. That's 6 millimeters. And E is probably the most important one, and that's called evolution. So if there is any mole, it doesn't matter what the size, it doesn't matter of what the contour, what the color, but if it's changing, that should bring one to a primary care physician or a dermatologist to take a closer look at this.
And could we add or put under the category of evolution a mole that bleeds, perhaps?
That's right. That's right.
So if it's growing, changing, bleeding.
Any change to a mole, even if the mole is small, it's round, the color hasn't changed, it's not asymmetric, but like you said, if now it starts bleeding, if you just, for some reason you cut it at the corner of a chair and it's bleeding, that should be something that you should go see someone for.
I see. Well, Dr. Eftimie, this is all fascinating to me. We only have a few more minutes. I wish we had hours to talk about this stuff. But now that we've talked about diagnosing a melanoma and how it develops, what do we do about it? Let's say a patient gets a diagnosis of melanoma. What's the treatment for melanoma?
So fortunately, melanoma actually is a very curable disease if it's caught in the early stages. So that's why it's important for anybody, if they see something suspicious, to bring it to the attention of their physicians right away. But the treatment for stages 1, 2, and 3, and some stages 4, is basically a resection, a surgery. Somebody like yourself goes in and takes out the melanoma. And if there's no melanoma anywhere else after a staging procedure, for most of those people, the treatment is done. There are some people that might benefit from some chemotherapy after the surgery, but by and large, most people, they get usually just a stage 1 melanoma. The treatment is surgery.
Okay. Well, Dr. Eftimie, that's great news that we need to emphasize that when caught in early stages, when diagnosed before it spread anywhere, melanoma is curable.
Very much so, very much so. The cure rates right now approach approximately 92% of people with melanoma will be alive at 10 years, which is actually a very significant number.
Great. Now, Dr. Eftimie, we only have about 1 more minute. Who gets melanoma? Is it young people, older people, men, women?
Everyone gets melanoma. It's usually equal men and women, although in the last 10 years, more men are beginning to get melanoma. Usually melanoma in men presents itself in the head and neck and the upper body regions, and the melanoma in women, it's usually below the knees. But everyone gets it, young, old, all ages, and that's why we should all be vigilant no matter what the age.
Does it run in families?
It can run in families. There is actually a syndrome called the FAM syndrome, which is familial atypical mole and melanoma syndrome. And that's usually in families who have 1 or more first-degree relatives with melanomas. And if you, the patient, have more than 50 moles on your body, then the chances of having that syndrome are relatively higher. In that case, those patients actually should be watched much more closer than the other patients.
Well, Dr. Eftimie, I'd like to give out your name and number in case people have questions about getting screened or they've been diagnosed with melanoma. And we're very lucky to have an expert like you around in this county.
Thank you.
Thank you very much for being here. So, Dr. Bogdan Eftimie, I'm going to spell it.
And I can give the number if you'd like me to.
Perfect. E-F-T-I-M-I-E.
That's right.
And you're here in town with the oncology group. There is an oncology group.
There's an oncology group. It's called Monterey Bay Oncology, and our phone number is 831-375-4105. 375-4105.
Perfect. And your group takes care of not only melanoma, but cancers of all types?
We take care of all types of cancers, including hematological problems such as thalassemias or sickle cell anemias.
Okay. Well, Dr. Bogdan Eftimie, you do a terrific public service. Thanks for teaching us, and I hope you come on the program again. There's lots for us to talk about.
I will come back. I hope so. Thank you.
I'm Dr. David Morwood. I am a board-certified plastic surgeon, and this is Your Health radio and television program. We're going to take a very brief pause for a very good cause. We're coming right back.